Hey guys, welcome to our channel Mrcp made super easy, where we make your journey towards Mrcp a fairly smoother and easier one, and we also ensure that our other viewers, whoever is watching this lectures, they understand the topic in a much better way so that it also helps them in our daily practice. So today we'll be dealing with a good topic called Achalasia Cardia. So without further delay, let's get into today's topic. Right. So Achalasia Cardia. Now what does Achalasia Cardia means? Now you need to remember that it is basically a condition. It is an acquired condition where there is some problem with the motility of the esophagus. So it is an acquired esophageal motility disorder where there is failure of the lower esophageal sphincter to relax. So the important part we need to know, in case of achalasia cardia, the lower esophageal sphincter, that is the LES, we'll refer to it as LES, or the lower esophageal sphincter, it is not relaxing. So since the lower esophageal sphincter is not relaxing, the food is not able to reach into the stomach, right? So as a result, we will have multiple symptoms like regurgitation, heartburn, and we will do each one of them in detail in just a little while. Right, so what really happens and why is this condition happening? Now let's look at a few basic physiology and anatomy of to what is happening. Now this is the esophageal lumen and this is the esophagus. Now the esophagus has multiple layers and layers of muscular layers and coverings that is happening. So over here you have something called as the myenteric plexus, right? So what is happening is there is destruction of the ganglion cells. There is progressive destruction of the ganglion cells. The cause can be autoimmune, or it can be acquired, or it can be idiopathic in nature. So there is progressive destruction of ganglion cells which happens in the myenteric plexus of the esophageal wall. So as a result of destruction of ganglion cells in the myenteric plexus of the esophageal wall, the lower esophageal sphincter, which is the lower esophageal sphincter, this one over here, right? So this is the lower esophageal sphincter, and from here it is the connection. The food then passes into the stomach. So this lower esophageal sphincter has to relax if your food bolus has to pass through the esophageal tube by the movement of peristalsis into the stomach. So when this relaxation of lower esophageal sphincter is not happening due to destruction of ganglion cells in the myenteric plexus, this leads to a condition called as achalasia cardia or dysphagia. As a result of achalasia cardia, we will have dysphagia, right? So you will have difficulty in swallowing, and the normal peristaltic movement that is happening, that will be lost, right? So achalasia cardia, it is a motility disorder which causes dysphagia as one of the primary symptoms. Why that is happening is because the ganglion cells in the myenteric plexus are getting destroyed. As a result, the lower esophageal sphincter does not relax. Peristaltic movements are lost, so the food is unable to pass into the stomach. Now this is the basic pathology as to what is exactly happening, right? So if you look at this diagram over here, it's a beautiful diagram. So you can see that the food bolus is supposed to come over here. This is the lower esophageal sphincter, and this lower esophageal sphincter is supposed to relax for the food to pass through. Imagine if this is contracting persistently, right? The food will not be able to pass into the stomach, right? So it will be pushed back. So if the food is being pushed back, there is no peristalsis happening in the esophagus. What is going to happen? You're going to have dilatation of the esophagus because everything that is coming down is being pushed back. So this tube over a period of time is going to become widened or dilated, right? So this is what is happening. So your lower esophageal sphincter is not working. So that's the main mechanism, right? So like I said above, failure of the lower esophageal sphincter to relax will make it difficult for the food to enter into the stomach, leading to dilatation or widening of the esophagus, as we can see very clearly in this diagram above. Now let's brush up on some basic physiology to know that what exactly is happening. Well, for those of you who have forgotten physiology, old physiology and anatomy, don't worry, we are here to help you. So the process of deglutition or swallowing happens in three phases. Now, I want you to picture this. You have started eating, you have taken food particle into your mouth, you're chewing that food. When you're chewing that food, you have submandibular glands and salivary glands over here. So in response to that food, the salivary gland will produce saliva. Now this gets mixed up with the food, and the food is then converted into a round ball-like substance which is called as the bolus of food. This is the first phase. So conversion of food into the bolus of food is called as the first phase, right? So then what happens is the food is pushed back, right? It comes and bounces up on the epiglottis. So the epiglottis separates the food pipe from the windpipe, right? This is a protection. So the food bolus falls upon the epiglottis, then enters into the esophagus. Then by involuntary movement, this is a voluntary movement. So the chewing part is a voluntary movement. This happens involuntarily. Once the bolus is passed into the esophagus, by movement of peristalsis, peristalsis basically means wave-like movement, right? So by that wave-like movement, the food passes down into the esophagus, comes up to then comes up to the lower esophageal sphincter and enters into the stomach, right? So you have two sphincters, upper esophageal sphincter and lower esophageal sphincter. Once the food is passed down, the upper esophageal sphincter will be contracting to ensure that the food does not come back up, and it pushes the food down by involuntary movements or wave-like movements called as peristalsis happening throughout the esophagus. The food gets pushed down all the way till it comes into the lower esophageal sphincter, and for the food to pass from the lower esophageal sphincter into the stomach, it has to relax. When that does not happen, we get dysphagia, regurgitation and heartburns, and that is what is happening in case of Achalasia cardia, right? Now this is a basic diagram of showing your stomach. Here you are your pancreas, the liver, here is your gallbladder, here is your duodenum and the intestines. A much clearer picture to help you understand. The food comes here into the stomach, goes all the way into the duodenum, right? Just follow this track. The twists and turns that are happening, then jejunum and into the ileum. Once it comes here, it goes into the large intestine, goes up all the way through the ascending colon, the transverse colon, the descending colon, up to the sigmoid colon, rectum, and then it is excreted out through the anal canal. So this is a basic diagram to help us remember how the whole process of swallowing is happening, right? Now this is a diagram showing you the stomach, the different linings of the stomach. Here is the esophagus, this is the cardia, this is the body of the stomach, the fundus, then you have layers, the serosal layer, the mucosal layer, and you have the muscularis layer over here, which again is formed from three layers: longitudinal, circular and oblique layer. Greater curvature of the stomach. Inside the stomach you have gastric rugae, this is the pylorus, the pyloric sphincter, duodenum, duodenal bulb. Okay, so this is to help you remember the basic anatomy and physiology of the stomach. Now something more important into the anatomy part. Now we need to know the muscles that are innervating the swallowing. Now why I'm stressing upon this is because this is a bit of an extra edge, and also it will help you answer other questions when we do the neurology part. So just look at this and remember, the trigeminal nerve, the fifth cranial nerve, supplies the muscles of mastication. Now some of you are going to ask me, what are the muscles of mastication? Well, I'm here to answer that. Now to remember the muscles of mastication, we have a mnemonic which is called as more tea less milk. More tea less milk stands for muscles of mastication, because if you really want to enjoy tea, you need to ensure that you don't put a lot of milk into it. So more tea less milk is our mnemonic. M stands for masseter, T for temporalis, L for lateral pterygoid, and M for medial pterygoid. So those are the muscles of mastication. So the fifth nerve, or the trigeminal nerve, supplies the muscles of mastication. It also supplies the mylohyoid, the tensor villi palatini, and the anterior belly of digastric. Now if you need another mnemonic for that, it is called MMTA. M stands for masticatory muscles. The masticatory muscles, you have the masseter, you have temporalis, you have lateral pterygoid, and you have medial pterygoid muscles. Apart from that, you have mylohyoid, the other M, T for tensor villi palatini, A for anterior belly of digastric. The next nerve innervating, you have facial nerve supplying the facial muscles, the stylohyoid, and the posterior belly of digastric. Next you have the ninth nerve, glossopharyngeal, supplying stylopharyngeus muscle. We have the vagus nerve supplying levator villi palatini, palatopharyngeus, salpingopharyngeus, intrinsic laryngeal muscles, cricopharyngeus and the pharyngeal constrictors. And last we have the hypoglossal nerve supplying the muscles of the tongue, the intrinsic muscle, the hypoglossus, styloglossus. Then you have the geniohyoid, the thyrohyoid and the genioglossus muscle. Now to way to remember it is the glossopharyngeal. Gloss stands for style. So gloss means stylish. So glossopharyngeal is a stylish nerve. So it has to supply a muscle which is stylish. So glossopharyngeus associated with stylopharyngeus. Gloss, style. So the way to remember glossopharyngeal muscle innervation is gloss is a stylish nerve. So it will supply any muscle that is very stylish. So glossopharyngeus is going to supply stylopharyngeus muscle. Right? The vagus will supply all the muscles of the pharynx except the stylopharyngeus, and the stylopharyngeus is supplied by a glossy nerve, that is the glossopharyngeal nerve. So this is the way to remember it, right? So once we have brushed upon the basic physiology and anatomy, we are going to look at types of achalasia. There are two types of achalasia, my friends. There is primary achalasia and there is secondary achalasia. The cause to primary is idiopathic, secondary probably due to some other underlying condition which is causing achalasia. So there are two types, primary and secondary. The cause of primary is idiopathic, whereas the cause to secondary is it is due to some underlying disease. Now, the epidemiology. Almost 10 in 1 lakh people suffer from achalasia cardia. The male to female preponderance is equal. Both male and female suffer commonly, and it commonly happens in middle-aged people. That is between the age of 30 to 60 years. An important point we need to know is people who have achalasia cardia, there are at a 7-fold increased risk of developing esophageal or esophageal cancer. Right? So that is why this is important. Now the causes. We have already mentioned about that there is progressive destruction of ganglion cells which is happening due to degeneration of the myenteric plexus neuron which is situated over the esophagus, as we have looked at in the diagram above. I have told you already the causes can be idiopathic. The second can be an autoimmune condition which is causing achalasia, which is causing destruction or degeneration of this myenteric plexus, leading to failure of the liver esophageal sphincter to relax. As a result, we get achalasia cardia. There can be a bit of genetic predisposition as well, like someone in the family is suffering from achalasia. There can be a chances that due to the genetic makeup, the other people in the family can also suffer from achalasia cardia. We can have secondary causes like gastric adenocarcinoma and lymphoma. Well, why? Imagine this is the stomach cancer. Now what is happening? It is situated in the area where you have the myenteric plexus. This cancer can cause damage to the myenteric plexus due to its situation, causing failure of the lower esophageal sphincter to relax, leading to achalasia cardia. That is why gastric adenocarcinoma or lymphomas cause achalasia cardia due to its location where the cancer cells can destroy the myenteric plexus, leading to destruction of the ganglion cells. Okay. Right. The other cause we have is infection. A very common infection that can cause achalasia cardia is called Chagas disease. We'll do a lecture on Chagas disease separately. For your knowledge at this point of time, Chagas is basically a parasitic vector-borne disease which is caused by bite of triatomine bug. Okay, so this is the bug that is causing the bite, leading to this swelling around your eyelids, and it is called as Chagas disease. So due to some mechanism which is involved with this parasite, we get achalasia cardia in patients who are suffering from Chagas disease. So causes are pretty simple: idiopathic, autoimmune mechanisms, genetic predispositions. Secondary causes can be cancers like adenocarcinoma of the stomach and lymphomas, and infections you have Chagas disease. Chagas is a parasitic infection which is commonly caused by a bug, triatomine bug. Okay. Now let's look at the signs and symptoms. Signs and symptoms. Since the lower esophageal sphincter is not relaxing, we're going to have dysphagia, which is a very important symptom. The dysphagia is very typical because you're going to have dysphagia to both solids as well as liquids, not just liquid or solid, but both solids and liquids. The type of dysphagia over here is a progressive dysphagia. That is, initially patients will have dysphagia to solids, but over a period of time they will develop dysphagia to liquids as well. Because of dysphagia, because of your sphincter not relaxing and food coming back, you're going to have regurgitation. Because of that, you're going to feel like you're going to have heartburns and chest pain, so you're not sure if you're having a heart attack or whether it is an acid reflux. because of excessive food regurgitation and acidity and all these things, you're going to have a risk of aspiration pneumonitis. So there's an increased risk of aspiration pneumonitis. Since you're going to be scared of eating because of all the symptoms that are produced, you're going to suffer from weight loss, right? So signs and symptoms are pretty easy. You're going to have dysphagia both to solids and liquids. The dysphagia can be to solids first followed by liquid. You can have regurgitation of food. You can have heartburns and chest pains. There can be risk of aspiration leading to aspiration pneumonitis, and there can be weight loss. Well, diagnosis fairly simple. To diagnose, there's only one diagnostic test which is considered as a gold standard out of the many that we are about to state, which is called as esophageal manometry. Right? What is it? I will tell you about it. So, to diagnose first, we can do a barium swallow study. If we do a barium swallow study, we will see that there is proximal dilatation of esophagus. As I have told you about that, the lower esophageal sphincter is not relaxing, so the food is being pushed back. So over a period of time, there is dilatation of the esophagus. So dilatation of esophagus, and the distal esophagus will be narrowed down, giving you an appearance of a bird beak. Now this is the bird beak. I have put this for, look at this over here, the shadow. So this represents a bird beak appearance, which is very typical of Achalasia cardia, which happens because your proximal esophagus is dilated and your distal esophagus is narrow. Right? This is another picture showing you Miriam's swallow study where you have a bird beak appearance. Next we can do upper GI endoscopy, but the problem with doing an upper GI endoscopy is that if the upper GI endoscopy comes back to be normal, it can be misleading because you don't know what the patient is going to be suffering from. So you can use the upper GI endoscopy to rule out other causes of for dysphagia, but a normal study does not rule out the possibility of achalasia. Remember that. Right, the gold standard test is called as a manometry. Right, so this is what a manometry basically looks like. There are three types. Basically, they are dividing into based on the study that they do. It helps you assess the contraction of the lower esophageal sphincter, and it will show you lack of peristalsis. So this is over here. This is type 1 where there is classic achalasia with failure in peristalsis. Now this is type 2 with pan-esophageal pressurization, changes in pressures, and this is the third where there is esophageal spasm. So basically you look at the changes in pressures, right? There will be increased pressure, right? So manometry is the gold standard for diagnostic of achalasia cardia. X-ray chest is also important because there can be widening of the mediastinum up to 6 to 8 centimeter. That is, if somebody is lying down, there can be a mediastinal widening of up to 8 centimeter in supine position, and in upright position a mediastinal widening of 6 centimeter should also raise a doubt that the patient might be suffering from achalasia cardia. Well, treatment, there are three ways to treat it. You have the basic behavioral changes, then you have pharmacological, and then you have surgical. Behavioral, you need to instruct your patient to chew their food properly and eat as slowly as possible, right? And they need to avoid eating before food to reduce the risk of regurgitation and acidity and heartburns. Pharmacological therapy, we have nitroglycerin and calcium channel blockers, both sublingual nitroglycerin and long-acting nitroglycerin. Why we use it? Because it reduces the lower esophageal sphincter pressure. So that's the role of calcium channel blockers and nitroglycerin. There is studies that show that Botox injections, during endoscope injected can, help in reducing the symptoms. But the problem with Botox is that the efficacy is pretty poor, and you need to give them multiple injections at every 6 months to 12-month period. So you have an elderly patient who is not fit to undergo a surgical intervention or a pneumatic balloon dilatation, then in that case you can prefer Botox injection. So it is reserved only for elderly people who are unfit for pneumatic dilatations and surgical interventions. Right. So we have another technique called as pneumatic balloon dilatation. Basically you pass a dilator and this lower esophageal sphincter area is dilated. But the problem with pneumatic dilatation is that there can be a 25% risk of esophageal perforation. So you need to assess the patient properly, right? So pneumatic balloon dilatation is again safer in older people and unfit patients, and it is a non-surgical option. But the only problem with that is there can be risk of esophageal perforation, and there will be a requirement of redilatation in this patient. So it's not a very good option, I would say. Next, the gold standard treatment method or the preferred method of choice for treatment is Heller's myotomy. What happens in Heller's myotomy is basically you cut the muscle of the lower esophagus and cardia. So, but that can result in GERD. So, what they do is they also do a fundoplication along with it. So, if you want to know what Heller's myotomy is, basically this is how it's done. Laparoscopically, they put in cameras into this area. They cut off the lower esophageal muscle is split, right? Over here, you can see they're doing a split over here, and then it is sutured back. So, a fundoplication is also done in order to ensure that gastroesophageal reflux disorder does not develop as a result of Heller's myotomy. So, Heller's myotomy is the best method for treatment, and the gold standard for diagnosis is manometry, right? And an important point to note is drugs like prokinetic drugs like metoclopramide are contraindicated in Achalasia cardia. The reason why we do that is because it increases the lower esophageal pressures, hence they are contraindicated in Achalasia cardia, right? So to quickly revise, Achalasia cardia is a esophageal motility disorder where the lower esophageal sphincter is not relaxing. Reason happens is because there is progressive destruction of the ganglion cells due to the myenteric plexus, basically involvement of the myenteric plexus, right? So as a result of that, you're going to have regurgitation, you're going to have heartburns, you're going to have chest pains, right? And dysphagia can be to both solids and liquids. The type of dysphagia can be progressive, first solids then liquids, right? To diagnose, you need to do basically a manometry, which is gold standard. Barium swallow will show you a bird beaking appearance, right? Treatment, mainly there are two: pneumatic dilatation and Heller's myotomy. Pneumatic dilatation can be given for patients who are unfit and older patients, but problem with that is chances of redilatation and requirement for redilatation are high, and chances of perforation are high. So the preferred choice of method is Heller's myotomy, where you cut off the lower esophagus, the muscle of the lower esophagus, and you combine it with a fundoplication to prevent the risk of GORD from occurring. Right, so that's going to do it, guys, for today. I hope you got something out of today's video. If you do listen to this lecture, you will be able to answer every single question that's asked on Achalasia cardia. So please do like, share, subscribe to our channel so you don't miss out on our daily updates. And if you have any questions, as usual, please do post it in the comment section. I'll be more than happy to answer. So until next time, take care and bye bye.